During these unprecedented times, our healthcare systems are facing unimaginable challenges to provide safe and effective care, not just for COVID-19 patients, but all patients living with serious illness. Palliative care can guide, educate, and provide comfort to patients and families during the COVID-19 pandemic. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hedderly, Senior Writer with AHA. In this episode, Marie Cleary-Fishman, Vice President of Clinical Quality at AHA, is joined by Diane Meier, a MacArthur Genius Awardee and Director of the Center to Advance Palliative Care at Mount Sinai Health Systems in New York City. They're discussing COVID-19's impact on caring for seriously ill patients.
Welcome, Diane, and thank you for joining us today to talk about this very, very important topic of caring for our seriously ill patients during this pandemic, this unprecedented pandemic that we're facing. Can you start by talking a little bit about your role with the Center to Advance Palliative Care, or CAPC as we know it, and Mount Sinai in New York City, which we know has been so hard hit by this pandemic?
Yes, thank you so much for inviting me to join you, Marie. I'm really happy to be here. I'm a physician, a geriatrician by training, and a palliative medicine doctor as well. And since 1999, I've been leading an organization called the Center to Advance Palliative Care, and we are a national nonprofit that sits inside the Mount Sinai School of Medicine in the Mount Sinai Health System. But we have both a national and an international audience, and our mission is to improve access to high-quality palliative care across the globe through the provision of training and technical assistance.
And then I also understand you have some connection with Mount Sinai in New York City. Can you share that a little bit?
Yeah, so I am a faculty member in the Department of Geriatrics and Palliative Medicine at our Mount Sinai School of Medicine. And during this pandemic, it's been all hands on deck. And as you can imagine, one of the greatest needs that has emerged from the very high volume of a large number of very, very sick people and people who became sick very suddenly has been the need both for expert symptom management, particularly management of shortness of breath, and expert communication skills. And here's a place where, because of the rapidity of the development of the illness, its severity, the fact that families cannot be with their loved ones in the hospital because of restricted visiting hours, the need for skilled communication about what is happening, what to expect, repeatedly over time is of the highest priority, and the frontline clinicians, frankly, are so busy and dealing with such a high volume of incoming patients who are very sick that we have essentially created a 24-hour-a-day palliative care hotline, so that any clinician in the entire healthcare system can call that hotline at any hour of the day or night and get patched through to a palliative care faculty member who will take information from them about the patient, how the patient is doing, how they look, take the questions from the frontline clinician, and then call the family to relay the report.
Yeah, that's amazing. That is such a great use of important resource, and I think I'm sure the frontline caregivers are very, very appreciative of having that resource available to help them care for these seriously ill patients, especially impacted by COVID-19. What are you seeing? And you talked a little bit about the shortness of breath and the breathing difficulties, but for those living with serious illness, when they're impacted by COVID, what exactly are you seeing?
Well, the number one thing we're seeing is fear and confusion. So patients, for example, who have cancer, who are normally getting a chemotherapy infusion, every 3 weeks. Those have been canceled. People with advanced heart disease or emphysema or dementia or stroke who are accustomed to rather regular interaction with and support from their healthcare teams are suddenly cut off. And they can access help, but not in person. They can't come into the office or the clinic because those are closed. And we have many, many people for whom thinking about telemedicine or video visits is like speaking a foreign language. And the level of tech savvy that is required to engage in these things is not trivial, number one. And number two, there's an implicit bias here because educated upper and middle class people are perfectly tech savvy. There are many populations in New York City who are extremely financially strapped, so for example, may not be able to pay to keep their phone on, and or are in a generation that doesn't hang out on the internet. So we're finding that these quick tech solutions are great for some people and don't work at all for others. And I'm very concerned about the latter group in terms of their sense of connection to their team, their clinicians.
And I would imagine that even further enhanced by the disconnection at times with their families and with that secondary support system beyond the clinical team. And
exactly. People are afraid to be together.
Right.
I was talking to the family of a 74-year-old. Everyone in the family speaks only Spanish, so this is all through translator. The son lives in one apartment with his wife and kids. The wife lives with her husband, who's now in the hospital, in another apartment. They both had been taking care of the patient, and they are both not feeling well as a result, and have not even known how to get in touch with the hospital to try to get someone to hold the phone up to the patient so that they can speak with him. And the level of complete lack of information and complete uncertainty about what they should do, what to expect, not only for their father and husband, but also for themselves because they're not feeling well, was absolutely stunning. And I think we tend to forget that access to good information and the ability to go out and get that good information is not equal across our society.
That's right. So you mentioned the palliative care availability and services as has been brought to Mount Sinai and to some of that work. What are some of the other best practices? We're seeing a lot of what I'm almost calling common innovation, but things people have done in other care settings being brought into the hospitals in order to care for patients who are seriously ill and who are dealing with COVID-19 during this. So what are some other best practices you're seeing in hospitals across the city to help care for these seriously ill patients at this time?
So it's remarkable the speed and breadth of innovation that has occurred over just a few weeks' time that under ordinary circumstances would have been either impossible to execute on or would have taken 10 years. So it's been stunning how quickly people can adjust and deliver on fundamental changes in how we care for people. And one example has been that we stood up a palliative care at home program literally overnight, over less than a week. So now any clinician in our healthcare system can, again, call it a different 24/7 phone number and say that they have a patient who chooses to stay at home, wants to stay at home, but in order to be able to stay at home, they need to be cared for, clearly. And as you may know, there's a desperate lack of personal protective equipment that is afflicting especially community entities like home care agencies, hospices and skilled nursing facilities. So relying on our usual community partners to take care of these people is not possible. So we had to stand up our own home-based palliative care program. And there were two things that were essential for us to be able to do that. One was to get access to these comfort packs. Those of you who are familiar with hospice will know that when a patient goes home with hospice, a box of symptom management medications gets put in their refrigerator to be there in case they need it. So, for example, concentrated liquid morphine, concentrated liquid lorazepam or Ativan, bowel medicines, nausea medicines. It just sits in a cardboard box in the fridge. But if the patient develops a symptom, there is a treatment for it, a few steps away in the patient's kitchen that the family can administer because they're very clear, straightforward instructions. So suddenly we had to be able to create comfort packs and get them delivered to people's homes 24 hours a day. And we were able to stand that up with our hospital pharmacy. They procured the meds, they created the boxes, we developed an instruction sheet with them, and they found a courier who could deliver to all 5 boroughs of the city, and actually Long Island and Westchester as well, 24 hours a day. But that's not enough just to have the meds in the house. There also has to be a trusted, trained expert at the other end of the phone 24 hours a day. Again, this is something that hospice provides, but nobody else does. And so we had to essentially provide what hospice provides, in this instance with physicians manning the phone, so that a family member at 3 a.m. who notices that their loved one is having trouble breathing can reach an expert at any hour of the day and night and say, here's what I'm witnessing, and let me show it to you on my cell phone. What should I do now? And so many people who did not want to come to the hospital or wanted to leave the hospital have opted for the palliative care at home program. And some of those people have weathered this and recovered, and others have not. But their choice is honored and supported in either case.
Yeah, I think that's a really, really important point. And Diane, in the work that we've done, we've talked a great deal about that, what matters, or goals of care. And I think, maybe you can just talk a little bit about that within this pandemic. Things are moving so quickly, and things are happening so fast. And as you've just beautifully described, with limited resources and in settings where the normal support is not there, how do we make sure that we're doing our best to respect the goals of care that patients, or that people in their homes, people who come into the hospital may have thought through, spent a lot of time committing to? How do we make sure we're respecting those goals of care as we continue to work through this pandemic?
Such a great question, Marie. Only about 20 to 30% of Americans have had these conversations, either with their families or with their clinicians. And the result is that we have no idea what they would want. And even worse, we have no idea who they would trust to make medical decisions on their behalf if they became unable to make their own decisions. Well, presto, we've got this pandemic going on where anyone could get extremely sick at any time, and suddenly the need for people to think about, number one, who they would trust to make medical decisions on their behalf, number two, talk to that person about our desire that they serve in this role, and number three, think about what we would want as individuals should we get so sick that we were not expected to recover to a meaningful level of function. And the way I talk about this with my patients is as follows. So I don't push anyone in any particular direction. I just say, some of my patients say that if they were so sick that if they were not expected to recover to be able to go home and return to their prior life, and were not expected to be able to interact or communicate with their loved ones, some of my patients say they still want everything possible done to prolong their life under that circumstance, no matter what, because any life is better than being dead. Others of my patients say that if if they were not expected to recover, to be able to have any meaningful interaction with the people they care about, that they really would want care focused on their comfort at that point. And then I say, which kind of person are you? So the point there is I'm not pushing anyone in any direction. They're equally valid choices. And I'm not asking people about what treatment they would want, whether they would want a ventilator or a feeding tube or dialysis, because you either would or would not want that if it was going to achieve a goal that was important to you. So if the person said to me, no matter what, I want everything humanly possible to prolong my life, no matter how bad the outcome might be for me, then they would get that ventilator, that feeding tube, that dialysis, et cetera. Whereas if someone said to me, no, I only want that if there's a meaningful likelihood that I'm going to recover and be able to go back to a level of human interaction that makes life worth living, then at a point where they were not expected to recover, I would know not to impose those treatments on that person. So it's about what is an acceptable quality of life. It is not about individual treatments. And I think some of the media coverage on this issue has focused a lot on, do you want a ventilator or do you not want a ventilator? And I think that's misleading and somewhat off the point, because of course you would want a ventilator if there was a meaningful chance of recovery. Almost everyone would. The circumstance where I might not want a ventilator is if I had end-stage dementia to begin with and were not, ever going to be able to have any kind of meaningful interaction, or if I had very advanced heart failure, and very clearly if I was so sick that I needed to be in an ICU and on a ventilator, there's very, very low likelihood that I would recover even to my current level of function, then I wouldn't want the ventilator. But if it's as I am right now, I'm 68 years old, reasonably healthy, yeah, I want that ventilator. I want every shot I can get at getting better. So it's much more about what's an acceptable outcome or quality of life than it is about an individual medical intervention. Am I making sense here?
Yes, Diane, absolutely. And I think, one of the things, and I think about, and as you know, I live to take care of my 88-year-old father who he distills it down this way. And he says if he can't get on his riding mower and go out and cut the lawn and do those kinds of things as an old country Irish farmer, then he doesn't want to have his life extended. And that's how it comes down to the conversation in my house. So thank you for sharing those important concepts and things that people are facing on a day-to-day basis in this pandemic that they may not have been thinking about or had to face in other ways. So related to that, Diane, can you talk a little bit about the palliative care resources that you have made available to folks across this country that are so useful when for providers who are caring for patients in this, or for families and caretakers that might be at home for people who have serious illness? I know you've got some wonderful things available, but could you talk just a little bit about some of those things?
Yes, thank you for reminding me to talk about that. On the CAPC website, capc.org, there is a free COVID-19 toolkit. And in that toolkit are a range of very practical, just-in-time resources to help clinicians take care of people with COVID-19. And this is all clinicians as well as palliative care clinicians. So for example, there's a pocket card that says how to treat shortness of breath. If the patient is opioid naive, what opioid dose do you begin with? How often do you redose it? Which drugs do you use if the person also has renal insufficiency or liver disease? On that same pocket card are some sample phrases or scripts with how to talk to patients and families about what to expect in this situation. So every single clinician taking care of COVID-19 needs that pocket card. And it can either be in your pocket, but that's probably suboptimal because you can't get at your pocket because you're in so much personal protective equipment. but they're also downloadable onto your phone. So trying to make things really quickly accessible and easy to people is our mantra on this. Secondarily, there are very easy to access, almost recipe cards for the management of other common symptoms, including pain, including nausea, which is an increasingly prominent symptom in COVID-19, and other common sources of distress. These are situations where often ordinarily our colleagues would call a palliative care consult, and they just may not have time to call that consult, and the palliative care team may be so swamped and so overwhelmed that they can't get to you quickly enough. So hence these basically just-in-time pocket card level guidance. In addition, there are a whole series of conversation guides. Many of these came from our colleagues at Vital Talk, a nonprofit organization that trains clinicians to have serious illness conversations. So examples of the conversations are, for example, telling a family member that their loved one is not doing well, or that their loved one seems to be needing a ventilator, or, and this is very sad but has happened a lot, coaching families through how to say goodbye by telephone to their loved one who frequently is on a ventilator and is sedated and cannot talk. But as we coach the families, very often we believe that people who are sedated and in intensive care units can still hear. And there are many stories of people coming out of a long stay in the ICU and recounting verbatim conversations no one thought they could hear, that they probably shouldn't have heard. So we are convinced that people can hear, and particularly that they can hear familiar voices, the voices of their loved ones. So there's a script offering to walk families through how to say goodbye under those very restricted circumstances where normally this is done in person. And we offer this and say that this guidance has been helpful to other patients and families we cared for. Would this be helpful for you? And then we go through what we call the 5 things to say, and we ask the family member to write it down, and we wait while they do so. So the first thing is to say thank you. Thank you for being my husband. The second is I love you. The third is forgive me. Please forgive me for anything I may have done that caused you pain. The fourth is I forgive you for anything you did that caused me pain. And the fifth, if it's time for this, is to actually say goodbye. And it is incredibly meaningful to families to have had that opportunity to say goodbye. And then in our experience, the families that suffer the most are those who did not get the opportunity to say goodbye and to say the things that really matter while the person is still with us. So we feel that it's really important to make that resource and that guidance available to every clinician who's taking care of patients with COVID-19.
That's wonderful. Thank you for sharing that. I appreciate it. And then just to kind of summarize things, Diane, I just want to say, we know that healthcare in general will never be the same from this, right? We're going to learn a lot of lessons, and hopefully we're going to make changes about that, even, life in general for that perspective. But what about palliative care? What do you think that palliative care will take away from this experience, and what changes do you hope that will happen in the field of palliative care going forward?
That's a great question too, Marie. The most obvious change, and one that I hope does not get stuffed back in the toothpaste tube, is the access to telemedicine and the ability to communicate with patients and families by phone or by video conference, and to be able to bill for that. The main barrier always has been that the restrictions on fee-for-service billing, with telemedicine, and yet during this pandemic, those restrictions have been basically blown away like mist. And the level of contact and communication that's been enabled because of that, and the ease of communication and the convenience and the safety, especially for patients and families, has been breathtaking. And this is true for primary care or cardiology care, as true as it is for palliative care. So aside from telemedicine, I think the other major innovation that I hope will outlast this pandemic is the 24/7 hotline access to palliative care expertise. This is a support to our colleagues all across the system, whether they're in a dialysis unit or an ICU or the emergency department or hospital medicine or a cancer center. When patients and clinicians need help, they need it now. And our current system is not designed that way. You put in the consult, you call it in, you get on basically you get on a triage list, you get seen when the team can get to you. And it is because of really legacy models of care that everything has to be in person and everything has to be documented in a certain way in order to bill, and the result is unnecessary delays in access to high quality care for people with serious illness. And I think we've learned that 24/7 access to expertise is essential, and we're getting hundreds of calls a day to this hotline in health systems, in our health system, which is quite accustomed to in-person palliative care consultation. But even though we're there, we can't respond to everything absolutely immediately. The hotline can. And it turns out that there's a huge demand for that, and I think we will continue it. The third innovation that I hope never goes away is the ability to meet people's needs at home. Right now, to meet people's needs at home is very, very difficult. If you are not hospice eligible, if you are not dying soon, if you have not agreed to give up life-prolonging treatment, you can't get hospice. So what can you get? You can get a Medicare-certified home health agency. A Medicare-certified home health agency does not provide palliative care at home. They provide skilled care for short-term needs, like wound care or learning to administer insulin. There's no way to deliver palliative care at home and get paid for it, and yet the vast majority of seriously ill people who are at home and need care are not eligible for hospice because they are not dying, and a certified home health agency won't meet their need. So I am really hopeful that the ability to deliver palliative care at home, which is where most people with serious illness need it and want to get it, will survive this pandemic as well.
Great points, Diane. Thank you so much. I think we are all looking for the positives that will come out of this pandemic, and those are definitely things that we can really look to in the future and hope they work to make them continue. So thank you. Thank you so much for all of this great discussion and this information. I think it's such an important time for those dealing with serious illness and for all of us as we move forward. Diane, thank you.
Thank you, Marie. I really appreciate the opportunity to be with you.